Streptococcus pyogenes, sometimes called strep pyogenes, can be broken down into strepto, which means chain, coccus, which refers to round shape, pyo, which means pus, and genes, which refers to forming. So, strep pyogenes are round bacteria that grow in chains, responsible for a number of infections that often present with pus. Strep pyogenes are also called Group A strep, GAS, in Lancefield classification developed by American microbiologist Rebecca Lancefield. Okay, now strep pyogenes has a thick peptidoglycan cell wall, which takes in purple dye when gram-stained, so this is a gram-positive bacteria. It's non-motile and doesn't form spores, and it's also a facultative anaerobe, meaning it can survive in both aerobic and anaerobic environments. Finally, strep pyogenes is catalase negative, meaning it doesn't make an enzyme called catalase. However, unlike other common cocci like enterococci, strep pyogenes is pyrrolidinyl arylamidase positive because it makes an enzyme called L-pyrrolidinyl arylamidase. To test for this, a small sample is taken from a suspected bacterial colony and then inoculated to a disc pad that's embedded with pyrrolidinyl beta-naphthylamide, another joy of a word. With strep pyogenes, pyrrolidinyl arylamidase hydrolyzes pyrrolidinyl beta-naphthylamide to produce beta-naphthylamide. Try saying that 3 times fast. Finally, another reagent called N-methylamino-cinnamaldehyde is added to the disc, and it reacts with beta-naphthylamide, resulting in a bright red color that confirms strep pyogenes is pyrrolidinyl arylamidase positive. When cultivated on a medium called blood agar, strep pyogenes colonies cause beta hemolysis, also called complete hemolysis. That's because strep pyogenes makes toxins known as streptolysins, which hydrolyze the hemoglobin in red blood cells to transparent yellow color byproducts. But some other Streptococcus species, like Strep agalactiae, are also beta hemolytic. So a bacitracin test is done to distinguish strep pyogenes. That's when a disc of bacitracin is added to the blood agar. Strep pyogenes is bacitracin sensitive, so the colonies die off, whereas with Strep agalactiae, the colonies remain intact. Now, strep pyogenes has a number of virulence factors that are like assault weaponry that help it attack and destroy the host cells and evade the immune system. So first, strep pyogenes is encapsulated, meaning it's covered by a polysaccharide layer called a capsule. And on the capsule, there are adherence proteins such as lipoteichoic acid, Streptococcus fibronectin binding protein, or SFBL for short, and M protein, which helps strep pyogenes attach to the host cells, like those in the skin or the pharyngeal mucosa. Then, strep pyogenes uses enzymes like hyaluronidase, which destroys hyaluronic acid, a cement substance that keeps cells of the connective tissues and blood vessels tightly linked. Destruction of hyaluronic acid results in local inflammation and enables the bacteria to spread to the bloodstream. In the bloodstream, strep pyogenes uses streptolysin O and S, which are toxins that cause hemolysis, or red blood cell destruction. It also uses erythrogenic toxins that are also called streptococcal pyrogenic exotoxins, or SPE for short, which come in 3 flavors: SPE-A, SPE-B, and SPE-C. This leads to increased hemolysis in the dermal and submucosal blood capillaries. What is more, SPE-A and SPE-C are superantigens, meaning they don't need to be eaten up and processed by an antigen-presenting cell such as a macrophage to generate an immune response from T cells. Instead, they interact immediately with the class II MHC molecule on the surface of the macrophage, forming a superantigen MHC complex, which then interacts with the T cell receptor and stimulates up to 30% of the entire T cell population. This is 300 times more powerful than the conventional antigens, and it stimulates the release of a whole bunch of inflammatory cytokines. Specifically, this is called a cytokine storm, and it can result in toxic shock syndrome, or TSS, which happens when a cytokine storm triggers widespread systemic vasodilation, making blood pressure drop, which leads to poor perfusion of vital organs. From the bloodstream, strep pyogenes bacteria can spread to other organs like the lungs, causing pneumonia or lung abscesses, or the heart, where they form clumps called vegetations on the heart valves, causing infective endocarditis. Alternatively, if they spread to the central nervous system, they can cause brain abscesses or meningitis. Surprisingly, despite all that powerful arsenal, Strep pyogenes can actually peacefully colonize the skin, the mucosa of the pharynx or throat, the vagina, and the rectum. It doesn't do any harm so long as the immune system keeps them in check, restricting their growth and preventing them from spreading somewhere else in the body. Problems arise in individuals with weaker immune systems, like infants and the elderly. Other immune-weakening conditions include HIV infection, diabetes, or a malignancy. In these cases, Strep pyogenes usually gets in the bloodstream through a breach on the skin, a mucosal laceration, or following surgery. Most often, Strep pyogenes causes strep pharyngitis, also called strep throat, which is the inflammation of the pharyngeal mucosa and tonsils. Strep pharyngitis may also be associated with scarlet fever, which is when intracapillary hemolysis results in a bright red skin rash. When Strep pyogenes infects the epidermis, it causes impetigo, which are superficial skin lesions that look like honey clusters. If the bacteria invades deeper, it can infect the upper dermis and superficial lymphatics, causing another skin infection called erysipelas. If it gets to the lower dermis, it causes cellulitis, which is an acute, painful, quick-spreading infection of the lower dermis and subcutaneous tissues. Sometimes, the infection can spread even deeper to the muscle fascia, causing necrotizing fasciitis, which is when the muscle fascia and subcutaneous tissue are destroyed in a process called necrosis. Finally, strep pyogenes can also cause post-infectious sequelae, which are complications that arise even after the bacteria has been eliminated from the body. For example, following strep pharyngitis, there may be acute rheumatic fever, or ARF for short. This complication arises because strep pyogenes has a bacterial M protein that mimics the structure of some proteins, which make up some tissues of the body, like the myosin and glycogen of heart muscle and smooth muscle cells. This is not to say that they're identical, but rather that they're similar enough for the immune system to confuse these self-structures with the bacterial M protein, resulting in a type 2 sensitivity reaction. This means that the immune system releases a whole lot of IgG and IgM antibodies that are aimed to destroy the bacteria M proteins, but instead attack the heart muscle, causing myocarditis, the heart valves, causing chronic valve damage, or the pericardium, causing pericarditis. Another post-strep pyogenes complication is post-streptococcal glomerulonephritis, which means acute inflammation of the kidney's glomeruli, most commonly seen after strep pharyngitis or after impetigo. It typically occurs 2 to 4 weeks after the initial infection because of a type 3 sensitivity reaction. This means that the streptococcal antigens that remain in the blood combine with antibodies and form antigen-antibody complexes that are deposited in the basement membrane of the glomerulus. This can activate the complement system and attract neutrophils to the glomeruli, resulting in kidney damage. Symptoms depend on the particular infection. With pharyngitis, there is fever, painful swallowing, and the tonsils look reddish and swollen, and there may be exudate on them. With impetigo, there are itchy, honey-colored scabs on the skin, which can become fluid-filled blisters. With erysipelas, there are warm and painful lesions on the skin with raised edges. With necrotizing fasciitis, there's fever, and the skin over the affected part becomes painful and purple-colored. With scarlet fever, there's fever, a bright red skin rash with a sandpaper feel, and sometimes the tongue looks like a strawberry. Finally, with acute rheumatic fever, look for the Jones criteria. Here's a mnemonic to help remember the major criteria. Jones, where J is for joint inflammation, O is for heart damage that causes new heart murmurs, N is for subcutaneous nodules typically seen on the elbows, knees, and the forearms, E is for erythema marginatum, a rash with thick red margins, and finally S is for Sydenham's chorea, which is characterized by rapid involuntary movement of the face and hands. With post-streptococcal glomerulonephritis, there is mainly facial edema and dark red urine, because glomerular damage allows red blood cells to pass in the urine. Diagnosis of strep pharyngitis can be done with a rapid strep test, or RST, which looks for bacterial antigens on a throat swab. So, when an RST is positive, that usually means that there is an acute strep infection. A caveat to this is that some people's pharynx is colonized by strep bacteria, and so a positive test should only lead to a diagnosis of strep pharyngitis if the clinical picture matches. Moving on, if the RST is negative, but the clinical suspicion for strep pharyngitis remains high, the next step is to do a bacterial culture from a throat swab, which has better sensitivity for detecting bacteria than the RST. Remember though, a positive result on the culture also needs to be interpreted in the context of patient's symptoms before making a diagnosis. Ultimately, the treatment of strep pyogenes infections is penicillin, because unlike some other streptococcal species which have developed penicillin resistance over time, strep pyogenes is still sensitive to good old penicillin G. For people who are allergic to penicillin, cephalosporins such as ceftriaxone and macrolides such as azithromycin may be used. Additionally, for necrotizing fasciitis, urgent tissue debridement is necessary. Alright, as a quick recap, Streptococcus pyogenes are gram-positive round bacteria that live in chains. They are non-motile, non-spore-forming, beta-hemolytic, and bacitracin-sensitive. They colonize the pharynx, vagina, or the skin, where they're part of the normal flora, but in some cases, they may take advantage of a weakened immune system and cause infections like strep pharyngitis, scarlet fever, impetigo, and necrotizing fasciitis. Post-infectious sequelae include acute rheumatic fever and post-streptococcal glomerulonephritis. Diagnosis may be done with a rapid strep test for throat infections or with a bacterial culture from the affected site. Treatment can be done with penicillin G, and alternatives include cephalosporins such as ceftriaxone and macrolides such as azithromycin.
With Streptococcus agalactiae, sometimes called strep agalactiae, strepto means a chain, coccus means round shape, and agalactiae literally means no milk. So strep agalactiae refers to the round bacteria that grow in chains and that was previously known to infect cattle, resulting in reduced milk production. Later on, strep agalactiae was found to also be a human potential pathogen, responsible for a number of infections that most commonly affect pregnant women and newborns. Strep agalactiae are also called Group B strep, or GBS, in Lancefield classification, developed by the American microbiologist Rebecca Lancefield. Alright, now a little bit of microbe anatomy and physiology. Strep agalactiae has a thick peptidoglycan cell wall, which takes in purple dye when gram-stained, so this is a gram-positive bacteria. It's non-motile and doesn't form spores, and also it's a facultative anaerobe, meaning that it can survive in both aerobic and anaerobic environments. Now, a particular trait of Streptococcus species is that they are catalase negative, meaning that they do not produce an enzyme called catalase. This is unlike other common gram-positive cocci, like Staphylococcus, which are catalase positive. When cultivated on a medium called blood agar, Strep agalactiae colonies cause beta hemolysis, also called complete hemolysis. That's because Strep agalactiae makes a toxin called beta hemolysin that causes complete lysis of the hemoglobin in the red blood cells, making the blood agar change color from red to transparent yellow around the colonies. However, other Streptococcus species, like Strep pyogenes, are also beta hemolytic. So to identify Strep agalactiae specifically, the bacitracin test, the hipurate test, or the CAMP test can be done. With the bacitracin test, a disc of bacitracin is added to the blood agar. Strep agalactiae is bacitracin resistant, so the colonies remain intact, whereas Strep pyogenes is bacitracin sensitive, so the colonies die off. With the CAMP test, Strep agalactiae is grown with Staphylococcus aureus on the same blood agar. Both these bacteria are beta hemolytic, but Strep agalactiae makes a substance called CAMP factor, which enhances the action of staphylococcal beta hemolysin. This results in greater areas of beta hemolysis where these colonies cross each other on the blood agar plate. Finally, the hippurate test is based on the fact that Strep agalactiae is the only hippurate positive strep, because it produces an enzyme called hippuricase or hippurate hydrolase. To test for this, a colony of bacteria is transferred from the culture to a test tube containing a special hippurate medium and incubated for 2 hours. Then a few drops of a substance called ninhydrin are added to the mix. With Strep agalactiae, hippuricase converts hippurate to glycine and benzoic acid, and glycine reacts with ninhydrin, making the mix turn deep blue or positive. Alright, now Strep agalactiae has a number of virulence factors that are assault weaponry and help it attack and destroy the host cells, and evade the immune system. First, Strep agalactiae is encapsulated, meaning it's covered by a polysaccharide layer called a capsule. The capsule also has pili, which are hair-like extensions that help the bacteria attach to a host cell. Additionally, the capsule is rich in sialic acid, which is a substance that can also be found in human cells. So inexperienced immune cells, like that of a newborn, might confuse Strep agalactiae with self cells, allowing it to survive inside the body. And finally, Strep agalactiae makes beta hemolysin, which destroys the host tissues and causes hemolysis, meaning it destroys red blood cells. Surprisingly, Strep agalactiae is very common, to a level that up to 30% of healthy adults are colonized by it, without causing any disease at all. They mostly colonize the gastrointestinal tract and the vagina. Problems arise in people with a weakened immune system, like newborns, pregnant women, and adults with underlying diseases like diabetes mellitus, malignancy, or a pre-existing infection like HIV. Additionally, since the spleen plays an important role in immunity against encapsulated bacteria, Strep agalactiae infections are more common in people who've had a splenectomy, meaning their spleen was surgically removed, or in those with sickle cell disease who have functional asplenia. Strep agalactiae can cause a number of infections. In pregnant women who are colonized with Strep agalactiae, bacteria can ascend from the vagina through the cervix and get right into the uterus. From here they can infect the fetal membranes, namely the chorion and amnion, causing chorioamnionitis. When this happens, these membranes can get damaged and then rupture before delivery time, resulting in a miscarriage or a premature delivery. Sometimes the infection can even spread to the fetus itself, causing intrauterine death. Alternatively, Strep agalactiae can get from the vagina on the perineum and make their way up the urethra, causing cystitis, which is the inflammation of the urinary bladder. In pregnant females who are colonized with Strep agalactiae, there's also a risk that they'll pass the bacteria to the newborn during natural childbirth. In newborns, Strep agalactiae is most likely to go down their airways, descend down the respiratory tracts right into the lungs. This can cause inflammation of the lung tissue, or pneumonia. Occasionally, Strep agalactiae can destroy the baby's alveolar lining with their beta hemolysin, and break through the alveoli capillary wall to get straight into the bloodstream, what's known as bacteremia. Bacteremia can cause neonatal sepsis, which is when bacteria triggers a widespread immune reaction that causes vasodilation, hypotension, and hypoperfusion of the baby's vital organs. Alternatively, bacteria from the blood can cross the blood-brain barrier and migrate into the cerebrospinal fluid, causing neonatal meningitis. Less likely, but possible, the bacteria can also travel down the bloodstream to the joints, causing septic arthritis. Treatment for Strep agalactiae requires antibiotics like penicillin G and ampicillin. For penicillin-resistant strains, or in individuals who are allergic to penicillins, cefazolin or vancomycin can be used. No vaccine for Strep agalactiae is currently available, so the only way to prevent infections in the newborn is to give colonized mothers intrapartum antibiotic prophylaxis, meaning antibiotics are given a couple of hours before delivery. Alright, as a quick recap. Strep agalactiae is a gram-positive round bacteria that tend to live in chains. It's beta hemolytic, non-modal, non-spore forming, catalase negative, hippurate positive, bacitracin resistant, and camp positive. This bacteria can colonize the gastrointestinal tract and vagina asymptomatically. Most frequently, it causes neonatal infections like pneumonia, sepsis, meningitis, and septic arthritis. But it can also cause chorioamnionitis or cystitis in pregnant females. Treatment relies on penicillin G or ampicillin, but cefazolin and vancomycin might be used as alternatives. To prevent strep A. galactii infections in neonates, intrapartum antibiotic prophylaxis can be administered to vaginally colonized pregnant females.
Streptococcus pneumoniae, or strep pneumoniae, can be broken down into strepto, which means chain, coccus, which means round shape, and pneumoniae, which refers to the fact that it causes pneumonia. No surprises there. So strep pneumoniae are round bacteria that tend to grow in chains, usually in lancet-looking pairs called diplococci. They're the most common cause of community-acquired pneumonia, meaning pneumonia acquired somewhere other than the hospital. Okay, now, a little bit of microbe anatomy and physiology. Strep pneumoniae has a thick peptidoglycan cell wall, which takes in purple dye when gram-stained. So this is a gram-positive bacteria. They're non-motile and don't form spores, and also they're facultative anaerobes, meaning they can survive in both aerobic and anaerobic environments. Finally, they're catalase negative, which means they don't produce an enzyme called catalase. Okay, now, when cultivated on a medium called blood agar, strep pneumoniae colonies cause alpha hemolysis, also called green hemolysis, because they produce hydrogen peroxide, which partially oxidizes the initially red hemoglobin in the blood agar to create green methemoglobin. Other Streptococcus species, like strep viridans, are also alpha hemolytic, so an opticin test is done to distinguish strep pneumoniae. That's where an opticin-containing paper disc is placed on a plate of blood agar that has been inoculated with the bacteria. With strep pneumoniae, the growth of the bacteria is inhibited in the zone that surrounds the opticin disc, meaning that strep pneumoniae is opticin sensitive. On the flip side, strep viridans are opticin resistant, meaning that there's no inhibition of growth around the opticin disc. Another test that can be used to distinguish strep pneumoniae from other alpha hemolytic streptococci is the bile solubility test. The bile solubility test can be done in a test tube, or more commonly, by dripping drops of bile on bacterial colonies. Now, strep pneumoniae is bile soluble, meaning that the bile salts will promote the lysis of the bacteria, whereas all other alpha hemolytic streptococci are bile insoluble, or bile resistant. Now, strep pneumoniae has a number of virulence factors that are like assault weaponry that help it attack and destroy the host cells and evade the immune system. So first, strep pneumoniae is encapsulated, meaning it's covered by a polysaccharide layer called a capsule. The capsule has pili and fimbriae, which are hair-like extensions that help it attach to a host cell. Once attached to a mucosal surface, like in the nasopharynx or the middle ear, strep pneumoniae can multiply and produce biofilms. A biofilm is basically a layer of goop-like material made of exopolysaccharides or EPS, within which strep pneumoniae bacteria live and reproduce. Comparing a biofilm to strawberry jam, the seeds would be the bacteria and the rest of the jam would be the EPS. The bacteria in the biofilm hide from the host's immune system and antibiotics, and even exchange resistance genes. Sneaky. Another virulence factor is pneumococcal surface protein A, or for short PSPA, which inhibits complement activation. This way, strep pneumoniae avoids the opsonization and eventual destruction of the bacteria. As if that wasn't enough, strep pneumoniae also produces toxins, and the most important one is IgA protease. IgA protease destroys immunoglobulin A, or IgA, which normally binds invading bacteria so neutrophils can destroy them. That's like a computer virus taking over the antivirus software. The next virulence factor is autolysin. Activation of this enzyme causes the breakdown of the bacteria and the release of its internal components. Released internal components further activate the host's immune system, thereby enhancing the local inflammation and destruction of the host tissues, like alveolar capillaries and pneumocytes. Now, one of the components released from the bacteria is pneumolysin, which is another virulence factor. Pneumolysin is a toxin that binds to cholesterol in cell membranes and forms pores, which eventually lead to cell lysis. And here's the most interesting part. Strep pneumoniae can actually peacefully colonize the nasal cavities and sinuses, where it doesn't do any harm so long as the immune system keeps them in check, restricting their growth and preventing them from spreading somewhere else in the body. Problems arise in individuals with weaker immune systems, like infants and the elderly. Other immune-weakening conditions include an HIV infection, diabetes, malignancy, or alcohol abuse. Additionally, some toxic compounds in cigarette smoke can weaken the local respiratory defense mechanisms, making individuals more susceptible to strep pneumoniae infections. Strep pneumoniae can cause a number of infections. One example is rhinosinusitis, which is when the mucous membrane lining of the nose and paranasal sinuses gets inflamed, resulting in fever, facial pain, and headaches. Strep pneumoniae can also invade the eustachian tube and cause an infection of the middle ear, or otitis media, which causes pain and an earache. Chronic otitis media can spread to the mastoid antrum behind the ear, where it causes mastoiditis. Finally, from the mastoid antrum, the infection can spread to the cranial cavity, which is one way strep pneumoniae causes meningitis. However, the most common disease caused by strep pneumoniae is pneumonia. Strep pneumoniae sticks to the alveolar cells, the pneumocytes, and releases pneumolysin, which leads to the destruction of the pneumocytes in alveolar capillaries. Pneumonia causes fevers and chills, chest pain, and a cough. In severe cases, strep pneumoniae can cross the alveoli capillary wall and enter the blood, resulting in bacteremia. Eventually, bacteremia can cause serious problems like sepsis, which can lead to hypoperfusion of vital organs. Sepsis caused by strep pneumoniae is particularly common in people with spleen problems, because the spleen plays an important role in immunity, especially against encapsulated bacteria. So strep pneumoniae infections are typically worse in individuals who have undergone a splenectomy, which is when the spleen is removed, or in those with sickle cell disease who have functional asplenia. Once in the bloodstream, strep pneumoniae can cross the blood-brain barrier, invade the central nervous system, and cause meningitis. With meningitis, people develop a fever, neck stiffness, and a headache. On rare occasions, when the walls of the paranasal sinuses are very thin, strep pneumoniae can get into the cranial cavity and cause meningitis. Strep pneumoniae can also cause pneumococcal endocarditis, forming clumps called vegetations that damage the valves. It can also infect the pericardium, resulting in purulent pericarditis, which is where pus collects in the pericardial sac. Strep pneumoniae can also spread to a joint, resulting in septic arthritis, or it can cross the blood-brain barrier and cause meningitis as a complication of bacteremia, rather than invading directly as part of a primary disease. Once it has crossed the blood-brain barrier, it can also cause an intracranial or spinal epidural abscess. Finally, strep pneumoniae can spread from the bloodstream to the peritoneum, causing spontaneous bacterial peritonitis. This is more common in individuals with cirrhosis who develop ascites or too much fluid in the peritoneal cavity. Diagnosing a strep pneumoniae infection relies on cultures from biological samples like pus, sputum, cerebrospinal fluid, or peritoneal fluid. Alternatively, PCR can be done to detect strep pneumoniae DNA. Individuals at risk of strep pneumoniae infection should get vaccinated. This includes young children below 2 years, as well as people over 65 years old. Other risk groups include those with chronic diseases, such as diabetes, HIV, cancer, and most importantly, those with sickle cell disease and those with functional asplenia. Currently, vaccines against strep pneumoniae are divided into two main groups based on their mechanism of action. The first one is the pneumococcal polysaccharide vaccine, also known as PPV-23, because it contains 23 purified capsular antigens, and this one is mostly recommended in adults. Another category is the pneumococcal conjugate vaccine, or PCV-13, which contains the capsular polysaccharides specific to 13 strep pneumoniae serotypes, bound to a non-toxic recombinant variant of the diphtheria toxin, called CRM-197, which serves as a carrier protein. PCV13 is recommended in young children. Finally, treatment for infections with strep pneumoniae requires antibiotics, and the classic first line of treatment are beta-lactam antibiotics, like penicillins G and V, or cephalosporins. However, strep pneumoniae has been progressively developing resistance against penicillins and its derivatives such as amoxicillin and ampicillin. So alternatives include fluoroquinolones, the combination of amoxicillin and clavulanic acid, as well as third-generation cephalosporins like ceftriaxone and cefotaxime. Ultimately, vancomycin and linezolid can be used. Alright, as a quick recap, strep pneumoniae is a gram-positive round bacterium that lives in chains. They are non-motile, non-spore-forming, alpha-hemolytic, opticin-sensitive, and bile-soluble. These bacteria are found asymptomatically colonizing the nasal cavities and sinuses, but they can take advantage of a weakened immune system, especially in very young or very old individuals, or those with diabetes, HIV infection, cancer, splenectomy, or those with sickle cell disease. They cause diseases such as rhinosinusitis, otitis media, pneumonia, and meningitis. The treatment of infection with strep pneumoniae involves the use of penicillins, but in the case of resistant strains, fluoroquinolones, third-generation cephalosporins, and vancomycin can be used. The term Streptococcus viridans refers to 5 groups of streptococci that include Streptococcus aeruginosus group, Metis group, Sanguinis group, Salvarius group, and finally the mutans group. And each of these groups has approximately 30 species that can cause disease in humans. So the more correct term would be viridans streptococci to reflect that there's more than one of them. Generally speaking, viridans streptococci can't be assigned to a Lancefield group based on their cell wall antigens. However, in the Streptococcus aeruginosus group, some species can be assigned to Lancefield groups A, C, F, or G. Now, viridans streptococci have a thick peptidoglycan cell wall, which takes in purple dye when they're gram-stained, so they're gram-positive bacteria. They're also catalase negative, which means they don't produce an enzyme called catalase. Okay. Now, when cultivated on a medium called blood agar, viridans streptococci colonies cause alpha hemolysis, also called green hemolysis, because they produce hydrogen peroxide, which partially oxidizes initially red hemoglobin in the blood agar to green methemoglobin. One way to remember this is to think that viridans means green in Latin. Some species in the Streptococcus aeruginosus group, however, can also be beta hemolytic or non-hemolytic. These guys are special little snowflakes. Now, other Streptococcus species, like Streptococcus pneumoniae, are also alpha hemolytic. So an opticin test is done to distinguish them. That's where an opticin-containing paper disc is placed on a plate of blood agar that has been inoculated with the bacteria. With strep pneumoniae, the growth of the bacteria is inhibited in the zone that surrounds the opticin disc, meaning that strep pneumoniae is opticin sensitive. On the flip side, viridans streptococci are opticin resistant, meaning there's no inhibition of growth around the opticin disc. Another test that can be used to distinguish strep viridans from strep pneumoniae is the biosolubility test, which can be done in a test tube or, more commonly, by dripping drops of bile on bacterial colonies. Strep pneumoniae is bile-soluble, meaning that the bile salts will promote the lysis of the bacteria, whereas viridans streptococci are bile-insoluble or bile-resistant. Finally, viridans streptococci also lack the polysaccharide-based capsule typical of Streptococcus pneumoniae. Viridans streptococci are commensal organisms that reside in the oropharynx, epithelial surfaces of the oral cavity, teeth, skin, gastrointestinal, and genitourinary tracts. So, they live alongside their host without causing harm unless there's a change in the environment. Inside the mouth, viridans streptococci, like Streptococcus mutans and Streptococcus metis, adhere to tooth enamel with the help of dextrin polysaccharide and aggregate, forming dental plaques, which can lead to dental caries and gum disease. In contrast, Streptococcus sanguinis promotes dental health by inhibiting the growth of Streptococcus mutans. However, when dental work is done, like a tooth extraction, viridin streptococci can enter the bloodstream and cause bacteremia. From there, they can make their way to the heart, where they may stick to a thrombus, an aggregate of platelets, red blood cells, and a mesh of cross-linked fibrin protein, on a damaged or prosthetic heart valve and cause subacute valve endocarditis. This usually happens on the mitral valve. Here, the microorganisms form small vegetations composed of bacteria and a protective sheath of fibrin-plated aggregates, which can detach and travel to different parts of the body as aseptic emboli. In fact, viridin streptococci, especially Streptococcus sanguinis, are the most common cause of subacute bacterial endocarditis in both adults and children. Children with central venous catheters, or immunodeficient states, like neutropenia in the context of chemotherapy, are especially at risk. A particular complication in children is viridin's group streptococcal shock syndrome, a toxic shock-like syndrome characterized by widespread systemic vasodilation, which leads to low blood pressure and poor perfusion of vital organs. Another viridin species, namely Streptococcus intermedius of the Streptococcus aeruginosus group, doesn't cause bacterial endocarditis. Instead, from the bloodstream, it lodges in other organs, like the brain and the liver, forming abscesses. In fact, Streptococcus intermedius is the species of viridin streptococci responsible for the most cases of brain abscesses. Now, symptoms vary depending on the infection. If the infection is in the mouth, symptoms may include bleeding or receding gums, bad breath, toothache, or tooth loss. With bacterial endocarditis, symptoms may include fever and a heart murmur upon auscultation. With toxic shock, there may be a fever, low blood pressure, and tachycardia. Brain abscesses associate neurological symptoms, like aphasia or the inability to use or understand words. With liver abscesses, there may be fever, chills, anorexia, malaise, and pain in the upper right quadrant. Diagnosis relies on cultures from biological samples, like abscesses, and blood cultures to identify viridin streptococci in the bloodstream. Alternatively, rapid antigen tests or antibody titers can be done. Additionally, an echocardiography can visualize heart valve vegetations. With a brain or liver abscess, imaging like computed tomography of the head and abdomen may show a mass. Treatment consists of the use of antibiotics like penicillin G. Other antibiotics with good activity include ampicillin, cephalosporins, vancomycin, and linezolid. Alright, as a quick recap, Streptococcus viridins is also known as viridin streptococci since it encompasses multiple streptococcal species that usually do not possess Lancefield antigens. Now, viridin streptococci are gram-positive, catalase negative, alpha hemolytic, opticin resistant, and bile insoluble. These are significant characteristics for diagnosis. The viridin streptococci reside in the oropharynx, gastrointestinal, and genitourinary tracts. They can cause wide-ranging conditions like dental plaques, dental caries, periodontal disease, brain and liver abscesses, and bacterial endocarditis. The mainstay treatment consists of the use of antibiotics.